if y'all can see me or not, but this way there's at least something for the screen. We are going to go over patient assessment tonight. Now, there's really nothing new in this from the last time you guys did this in basic. So I'm not going to pull up the 80 something slides or 120 something slides that we've got to go over because you've seen it already. What I do want to do is refresh you on it from the school perspective. I want you guys to understand kind of how the registry wants you to think about it. It'll help you make sense of the way that the questions are written on the registry. And also, I want to teach it to you from more of a team lead perspective. So what we're going to do, this is going to be a very interactive class. I'm not going to do all the talking. I don't like doing all the talking anyway. What I'm going to do is I'm going to pull up the roster. Don't you guys go running away on me. And we're going to do, I'm going to give you guys a breakdown of how I want the assessments to go. And then we're going to start doing a few rounds of it. And as long as everybody's rocking it and doing well, then we can get out of here. And this may not be that long of a class. Because there's really, like I said, there's really nothing new to learn. So to get started, let's start with this. I say 3, well, maybe 4 if you count ongoing. I say there's 4 sections to the full assessment, no matter whether you're doing medical, trauma, or BLS. So your first section is your scene size up. Second is your primary. Third is your secondary, and then you have your ongoing. Within the secondary assessment, that's where your vital signs and your history and your head to toe are. So I consider all that to be secondary assessment. It helps kind of break it down a little bit easier. That being said, who remembers from basic what the steps of the scene size up are? Can anybody tell me that?
Does anybody remember E-names? That's my question. I used that on Saturday, and everybody was like, so you have your BSI scene safety, and then you're going to figure out your number, your environment, your number of patients, your additional resources, mechanism of injury, nature of illness, your extrication of where you're going to go, how you're going to get out, get your patient out, and then spinal precaution. And this is kind of where I start. I mean, it's later down in the assessment, but I kind of start thinking, okay, are we going to load and go, or are we going to stay and play?
Right. Yep. All right. So I usually make that decision at the beginning of the primary. So when we're talking about the size up, and I try to teach it in an order that makes sense, there's 6 steps in the scene size up. First step is all about number 1, which is you, right? You want to make sure that you yourself are safe and you don't become patient number 3 or however many you've got plus 1. Don't be a blue canary. Sorry if there's any cops in here. So BSI scene safety. Each of your 3 priorities in the size up comes with 2 steps. Taking care of number 1, BSI scene safety. That's 2 right out the gate. We say them together, but the the checklist actually lists them separately. Step 2, or second priority, is like a quick triage. So what am I dealing with? What kind of scene is this? I'm not worried about a set patient yet. I want to know, is this a car versus a tree? Is this a stubbed toe? Is there hazmat involved? Whatever. Is it a bus? You know? So quick triage, that's how many patients do I have and do I need additional resources? And additional resources doesn't necessarily always mean extra ambulances. It may be that you need the fire department if you're not the fire department. It may mean that you need police or a hazmat team, sorry. Anything of that nature that can help you stabilize the scene. And then your last step is, now I'm looking at a patient that I'm going to be potentially working on. What's wrong with them? So nature of illness, mechanism of injury. And then we always consider C-spine, no matter what, as the last step of the size up. Because what if it's not trauma? What if it's medical, like a stroke? We don't normally think about putting a collar on somebody, but looking at the the mechanism of injury, nature of illness, does it look like they might have hit their head? Did they fall from a standing position? Do you think they may have hit the toilet if they're by it? That sort of thing. Because a lot of times we respond to people that are stuck between the toilet and the wall, and y'all have probably all seen this. They had a sinkable episode because they bore down too hard and passed out. Did they hit their head on the way down? Did they get it wedged in there weird? So it may not be a trauma call, but you may still have to do a C collar. So we always consider that at the end of the size up. And when I'm teaching basics, that's the way that I like to teach it, because it builds they fly through this size up, and you don't have to know it in order, but we teach it in order. If you can build that momentum, then by the time you hit your primary assessment, where you really do need to be in order, um, you've got that momentum, you've got that confidence, and you're just rolling right along. And you're not sitting there trying to think about, all right, what am I doing next in my primary, while trying to remember what you forgot in your size up. Because if you skip a step, it's going to be with you. And now you're like, crap, haven't even got to my primary and I already forgot something. What did I forget? And you're splitting your attention. The registry, the patient assessment at the advanced EMT level will make or break you, just like it did as a basic. You guys are still at the technician level, not the clinician level. So when you take the registry, you're going to find that it almost feels like an EMR test. It's not hard. The questions are very basic. But what people get tripped up over is that they start trying to outthink an EMT. If you start with the basics and work your way up, and you do this from a systematic approach, just like you did as when you were in EMT school, you're going to rock it. If you go in and you get bent around the axle of, well, he's got this disease and these vital signs and blah, 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 and I'm going to give this medicine, you're probably going to miss the question, because most of them aren't asking you what you're going to do to fix the problem. They're asking you what your next step is, or what's your first step, and they're really just referring back to your checklist. And for those of you that take the registry after June 30th, they're really going to be doing it, because you don't have a psychomotor skills exam anymore. You're not going to be doing the checklist in a room with an evaluator. It's going to be built into the registry. So I want you to approach every single question with your checklist in mind. Treat it, even though you're in the registry exam, treat it like you're sitting in the room doing your psychomotor. All right. So that being said, if I'm going to ask you what your first step is, what's your first step? If that's all I ask you, what's your first step? What would your answer be? We don't need any more information than that. Anyway,
PSI scene safety.
PSI scene safety. Anytime you get a question that says, what's your first step? It's always going to be put your gloves on, because you're going to get some scenario questions that, they say, all right, you got out of the truck, you're at a scene of a bus wreck and blah, 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 and you show up to replace an EMT who's giving you a patient with these vital signs, and they've got this intervention done and everything and blah, blah, blah. And what's your first step? And most people go, okay, well, I'm going to do this for the patient. Your first step is put your gloves on. Don't get tunnel vision for what you're dealing with. That you'll find those on the registry. Whatever your first step is, if that's what it asks you. And what my trick to the registry, because I'll refresh using the registry, that way I'm keeping up with how the test goes. When I get a scenario question and I've got vital signs and all this other stuff in there, I skip it. I go right to the very end of it, and I just look to see what's the actual question, because they're going to give you all that filler, and then they're going to say, what's your first step? Well, if that's my question, I can just ignore I can ignore everything else and just look for the BSI scene safety answer. And that whole block scenario was answered in 30 seconds. If that. The next thing that the registry may ask you is, what's your next step? Now, that's what leads me into the next part of our assessment. The only thing that the registry wants you to know in order is ABC or CAB. Right? So let's talk about how we're going to know which one to do. If you look at your CPR training, you're taught CAB. If you look at your registry training, it's ABC, as long as they have a pulse. And then if you're doing CPR, of course, they agree with CAB. So we've covered the scene size up. Who wants to tell me all the steps of your primary assessment in order?
So for your primary, you're going to do a general impression as soon as you walk in, and then you're going to go into your ABCs. I believe it's check for disability exposure, chief complaint, and then go into priority of patients and transport decision.
Okay. So you're like 80% there. just right out the gate. And a lot of that's drawn from previous experience, right? Let me ask you this. What order are you going to do your ABCs in? Is it ABC or CAB? Based on what you said.
So depending on whether it's a trauma or a medical.
Okay, not necessarily trauma or medical.
So don't they use a
What's
mnemonic XABC now?
so they do. If you're worried about trauma, like with X being the exsanguination, if you're going to put a tourniquet on somebody, that would happen before A. So to determine whether or not you're going to do ABC or CAB, think like CPR, right? You come up to a patient and they're unconscious on the ground. Let's say that's how I see them. So my general impression is poor, because your general impression basically is sick or not sick. If you walked in the room and I was your patient and you're like, hey, my name is Joel. I'm going to be your advanced EMT today. What can I do for you? And I'm like, ow, my stomach hurts. I need to go to the doctor. The far one, because they have my medical records. Do you have a good or bad general impression of me? Do I sound sick?
Oh,
There you go. That was not a rhetorical question. Yeah, no. So I don't sound that bad, right? What I'm saying and what you're seeing don't match up. So good general impression. All right. Now, if you walk in the room and I'm just passed out on the floor, that's a bad general impression. Or if you walk in the room and I'm clutching my chest and I'm sweating and you can just tell I look like I'm about to die in front of you, that's a bad general impression. So now the pucker factor is getting up there, right? We don't want the fecal matter to hit the fan blades, however you guys want to look at it. Now I'm going to start to really be a little bit more concerned that high priority for transport will be made. You can make that decision there. But ABC versus CAB, I don't to not get bent out over this is think of it like when you took CPR. You didn't just start doing compressions on somebody, right? You had that whole lead up. Is my scene safe? Yes. All right, cool. Hey, are you okay? So these are the missing steps that we didn't get a second ago. The first thing you want to do is check for your level of consciousness. And at the primary assessment, at the beginning of it, AVPU is fine. You don't have to go down the GCS route right just yet. You can do that later. I just want to know, are you alert, verbal, painful, or unresponsive? If you are alert, verbal, or painful, I can assume that you have a pulse, at least for the moment. So I'm going to go ABC. However, if you're unconscious, I need to do something. And again, think back to just basic CPR training. What do we do?
look, listen, and feel.
Before that,
Check a pulse.
you're checking breaths when you look, listen, and feel. What do I want to check? Pulse, right? If I have an unconscious patient on the ground at my LOC, if they're unresponsive, they may be a corpse. I don't know. They could be unresponsive because it's a sugar issue, which means that they probably do still have good vital signs. They're just unconscious. Or they could be unconscious because they're in cardiac arrest, and that's my concern. So I'm going to check a pulse in the neck, and if I don't feel one, I just restructured my ABCs to be CAB because I have to do compressions now. If I do feel a pulse, then I'm going to do ABC. So the beginning of your primary is done the exact same the way that you were taught in CPR. The same way we teach high schoolers CPR, that's your primary assessment. It's the exact same thing. We don't do a good job of making it simple like that. Like it's real simple in CPR, but we try to make a mountain out of a molehill in EMT, an advanced EMT for whatever reason. But that's what you're doing. So come up to your patient, real quick general impression, kind of crappy, mainly because he's passed out in a lump on the floor. So I'm gonna move him over. Yep, no pain response. Sternum row doesn't do anything. I'm gonna check a pulse. He's got a pulse. All right, cool. Airway, breathing, circulation. Or
Rob,
he has no pulse. Compressions first. What's up?
are we sharing the chat room with the basic students? Because I'm seeing basic questions coming up.
I see one basic study because the bacteria populates the antibody. What? And then
Yeah, that's what I said.
1 second.
Just want to make sure we're not confusing them and vice versa.
So it's possible. Let me see if Charlene is in the right room. Oh, Hope Starnes needs to be moved. Charlene's in the right room. Interesting. I don't know why hers, she may have typed directly into the chat of Teams itself rather than in the window, the meeting window. All right, Hope, I'm sending you over to the EMT room so you can actually hear your lecture for the night. You should have got a little pop-up that asked you to move over to it. You have to accept it. I can't force you in there. There you go. All right. Yeah, so if you see any B124 students pop up in here, just ignore them. They are all in their room, so they should be fine. All right. So that's your primary assessment, right? ABC versus CAB. The difference being whether or not they have a pulse, and you can treat it just like you did with CPR. Once we get to the secondary assessment, now this is where I'd factor in vital signs, history, and a head to toe. If it's trauma, I'm gonna go ahead and do the head to toe, the whole poke, feel, whatever, just like you did, because and I'm not gonna fix anything, right? We're at this point, we are past the life threats. Now I just want to know how I'm going to move my patient. So if it's trauma, I'm going to do my head to toe first, and I'm just going to note everything that I find. Broken bones don't matter right now. Non-life threatening bleeds don't matter right now. I'm just looking to see what I've got. Deformities, all that, the decap BTLS stuff. I'm not going to fix it. I'm just looking to see what I got, because if I have a fractured hip, I need to know not to roll my patient onto it. That's the idea there. Once you get him in the truck, then you can start doing everything else. So you can do your vital signs, you can get your patient history. If you've got somebody to ask, if your patient's unconscious or whatever, if you can't get it, you can't get it. But do your head to toe first. The only other thing that I will say is that it's still up to you. The registry doesn't say that you have to do that first. That's just some experience-based stuff. It makes it easier for you if you're in a trauma call. Head to toe first, and then you have your vitals and your history. Which one do you do first, vitals or history?
History.
Okay, we got to vote for history. Anybody disagree?
Vital.
I say equals.
I heard pupils. Did somebody say pupils?
Vitals.
Vitals. All right, so we got people for vitals, people for
Vitals.
history. More vitals. Let me ask you
I
this.
think, is the patient conscious or not?
That's a good question. So what I'm getting at here is that once you get into your secondary assessment, there really is no one before the other. There's nothing saying that you have to do your vitals first. There's nothing saying you have to do your history first. It's going to be patient dependent. If your patients, you may not think you're going to get very many questions out of them before they pass out on you. You may want to start with your history. If they're already unconscious, if they're unconscious, they can't answer questions. So just get your vitals. The only thing that the registry can ask you that's in order is your primary assessment. And I want you to think about that every single time the registry asks you a question. If it says, for example, and they're not as obvious with it at the AEMT level as they are at the basic level. In the basic level, they would actually come out and say, what's your next step? So if I were teaching EMT basics tonight, I would harp on that. Like, look for that phrase. If you see that, then now you have to figure out where you're at in your primary. If you just did an airway adjunct, your next step, that's A, right? So your next step would be B. Your answer is give oxygen. If you look at your options, you may have suction the airway, give oxygen, apply a tourniquet, get vital signs. And all four of these things are in your assessment. So they're all four going to look right. But that's not what the question is asking. The question is asking you, what's your next step? So, maybe if it was a tourniquet, you should have already put it on. If they're not gurgling, then you have nothing to suction, so that's not it. If you, assuming that you just give an adjunct, right? So if I said you put an OPA in, what's your next step? The tourniquet should have already been done. Unless they're gurgling, you shouldn't have to suction them. Vitals is in your secondary assessment, so that's way down the line. The only thing left is give oxygen, and that's B anyway. So you're going through your letter steps. Between first step and next step, that's going to be about 80% of your scenario questions. And that's what makes the registry hard. At the advanced EMT level, you guys get a little bit less obvious questions. Like, trying to remember how one was worded the last time I took it. It said you come across a patient with agonal respirations and a pulse. So we're not doing CPR. They have a pulse, but their breathing is not adequate. And they say, what will you do? And I have put an OPA, bag my patient, give oxygen, and then some other way down the line thing. I'm going to do 3 out of 4 of those, right? I'm going to put in the OPA. I'm going to bag my patient with oxygen. Which one's going to happen first, though? Because we're dealing with a primary assessment issue.
Say bag.
Okay, so we can bag the patient.
Airway.
I was about to say, do we bag them before we put the OPA in, though? So remember, bagging your patient can be both an airway fix and a breathing fix, depending on the issue. If they're not breathing, you're bagging them to give them breaths. That's a breathing fix. If it's a CHF patient, or which we'll get into that in a couple nights, or if let's say it's a near drowning victim where they've got fluid in the lungs, the bag is solving an airway problem. Because I know you guys have heard this, right? Your airway fixes only go to the cords. You can't go past the cords. Only paramedics can go past the cords. That's not accurate. The plastic you use can't go past the cords, so you can't do an ET tube. However, the BVM used as an airway fix goes all the way to the alveoli. If you're shoving fluid back out of the lungs because your patient's drowning in dry air, your BVM, the CPAP, that's if they're conscious, that's what that is. That's an airway fix. So when you're looking at options on your registry and you're trying to order them of what you're going to do, look at what the intervention is and then say, is that an airway, breathing, or circulation fix? And if it's an airway fix, then it happens first. If it's breathing, then it comes after airway, so on and so on. That way, what's your next step starts to become a much easier question. Is that jiving with everybody?
So the airway was the correct answer, because if I'm able to ventilate that patient with the bag, I don't need the airway.
With it without the adjunct. If you don't need the adjunct, but you can bag without any resistance, do you need the adjunct in order to do it, quote unquote, correctly?
So there's 2 ways to look at that. One is from the registry perspective. If the question makes you think that they need it, so let's say they're snoring, then put it in. And really, I would say if you're going to err on the side of caution with the registry, and again, I'm speaking to the test here, put it in. Just be safe. Just go ahead and put it in. If they're completely unconscious, put an OPA in. If they're somewhat conscious, go with the NPA, or the supraglottic, if that's what your question gives you. Realistically, if they're still somewhat with it and they are maintaining their own airway, then no, you don't have to stick a piece of plastic down somebody's throat if they don't need it. But that's going to be one of those where you separate your street smarts from your book smarts. The test is going to assume that you have not set 1 foot in the real world. They can't quiz you on that. They can only quiz you on the academic side. So for the test, put an OPA in, or whatever your adjunct, whatever it mentions, put it in.
Copy.
So A before B. That way you don't mix up your primary, because again, they're not actually quizzing you on whether or not you need an airway. They're quizzing to make sure that you know to do airway first, then breathing, then circulation. Any questions on any of that? All right, let's finish up the secondary assessment walkthrough, and then we're going to take a break. And when we come back, we'll start doing some scenarios, and everybody rocks through the scenarios. We'll call it a night. We'll be, like I said, we'll make it a quick chapter. This stuff is more of a review. There's nothing new. The assessment's the same for all levels. So we're just refining it tonight. And we're going to talk about some team lead stuff to kind of help you guys get used to being the ones that are calling the shots rather than just standing there while the paramedic is telling you what to do. All right, so in the secondary assessment, remember, it's personal preference what order you do things in. From experience, I say trauma, do your head to toe first so you can get them in the truck, but that's not a requirement. So if you want to do vitals first. If you want to do history, do your history first, your questions. It's up to you. The only other thing that I will say is whichever one you choose, get all of them. Then move on to the next one. So don't do blood pressure first and then ask them what they had for lunch and then go back and get a pulse and then ask them where it hurts and all that stuff. Don't do that because you're going to lose track of where you're at. So if you choose vitals, get all the vitals. What are the vital signs that we need to get as advanced EMTs?
Oxygen levels and respiration.
All right, so O2 and respirations. What else? Yep, we'll get to sample in a second when we get to history. But for vital
Your
signs, we've
pulse.
got O2, pulse, respirations,
Blood glucose.
glucose. Now, do I need to get a glucose on everybody? Every single human being I come in contact with?
No.
Yes.
There's
No.
schools of thoughts on that. So I personally say no. If my patient is alert and oriented, I'm not checking a glucose. However, would I be wrong to do it? No. So if you want to get it on everybody, you can, but that's up to you. But if they are altered, you will absolutely get a glucose. Don't not get that vital sign if they're altered in any way. They don't have to be unconscious. They could just be confused, right? They don't know where they are. Get a glucose. All right, that's insanely important. So we've got, okay, so Riola put it into the chat. We have blood pressure, pulse, respiration, CBG, SpO2. Y'all mentioned respirations. So the respiratory rate, not everybody is 16 a minute. I know we like to write that. And then there's one more. Actually, I see it up there. Yeah. Josh Lander, you got it. Capnography. Anybody familiar with capno? Have y'all learned that in just in experience yet? Or I don't know, we haven't covered it because it would technically be covered in this chapter.
I know how to put it on, but I don't know what. Like I don't know, and I know it measures like the carbon dioxide that they're breathing out. I just don't know like wavelengths and numbers.
Gotcha. Okay, so when we come back from break, I'm going to go into Capno. I'll share the screen and show some stuff with that. Capno is if I had to pick one vital sign that was the best of them all, I would go with Capno, followed by blood pressure. If I had to pick a vital sign that was a complete and utter total waste of time, O2 sat. Yeah, and that's a soapbox I won't get on. but yeah, we're gonna get those vitals. Try to get them on everybody. End title, you don't have to get on everybody unless you have a reason to believe that their respirations are not adequate. What was it that I said? Oh, glucose. You can get it on everybody if you want to. I prefer not to stick people if I really don't expect anything to be out of the ordinary. So if they're alert, oriented, everything's fine. Sometimes I'll forego that. Can I get a glucose from the blood in the IV catheter? Okay. So we've got 2 votes for yes. Let me ask you
Can
this.
you or should you?
Okay, yeah, but physically you can. Let me ask you this though. How accurate do you think that reading will be if it comes from a vein?
CBG, capillary blood glucose. It's probably not measuring what it's supposed to.
Exactly. Your sugar content on the vein side is going to be lower than if you were to get it from the finger because more of it has been traded off by the time it gets into the veins. So if you were really worried about their blood glucose being out of range, don't trust what you're getting from the IV catheter. You can do it. Like again, if you're just wanting to get it just to write it in your report, that way you've got it and they're fine. And I wouldn't stick them, right? If it's somebody that I would say, like, you know what, I'm not going to stick them. But the med director wants a number. So I'm going to pull it from the IV catheter just to get a number and I'm going to put it there. That's probably a bad habit, but I would not have stuck them anyway. So what difference does it make? At that point, yeah, fine, because they're telling me they stubbed their toe. Why do I care what their blood glucose is? If they're unconscious or altered or something like that, however, I really want to get an accurate number because that vital sign is now suddenly much more important. So at that point, stick the finger. Yes, you could get it from the IV catheter. However, the number's probably going to be wrong. The machine is not calibrated to that blood, and you may make a bad treatment decision based off of a wrong number. So don't get into that habit on all patients. But if you want to use it just because you want to put a number down, go for it. All right. So that's the vital signs. Moving into the history. Can I get a sample history on every single patient? Assuming
Harder on
assu-
unconscious ones.
I was about to say, assuming that there's somebody there to answer the questions.
Yeah.
Yeah, so you can get a sample on pretty much everybody as long as somebody is there that knows the answers. So if I'm your patient and I'm awake, I can tell you the answers myself. If I'm your patient and I'm passed out, my girlfriend can tell you the answers probably. But you know, I don't have to be awake to give you those answers. Somebody else that knows me can do that. What about OPQRST though? First of all, what are those questions about?
It's got to be first person. It's the person that has the pain that can answer those.
It's absolutely going to be a first person. Nobody can answer those questions but the patient themselves. Let me ask you this. Do you need to ask those questions if somebody broke their ankle?
Probably not.
Probably not. Why not?
I don't think that it's going to be related or pertain to the treatment.
Pretty much. They're going to look at you like you're crazy when you say, what makes it worse? And you look down, you're like, I broke my foot. What do you think? don't move it. You know, that kind of thing. OPQRST is for pain of an unknown origin. So
you still need part of OPQRST though for any kind of pain.
You might need to know the onset. That way, if you're
The
worried
severity.
about C-spine or something like that, well, again, a broken ankle is probably going to be a 10 out of 10.
Well, because I was thinking like severity or pain level, or does it radiate anywhere?
If I broke my ankle, it really doesn't matter if it radiates, though.
Unless you have a knee injury with it, which I've seen in the field.
True, but you would probably find that in your, because we're talking about deformities and major issues there. You're either going to find the deformity or you're not, and it's going to take a CT or a X-ray, neither of which do we have in the field. OPQRST really, for the most part, is going to be for your pain of unknown origin, not just pain itself, not pain for the sake of being pain. So if I told you I had a stomach ache, absolutely ask me OPQRST questions because that's going to narrow it down. Most people think when they say stomach, they're talking about their intestines, like down around the belly button and below. Your stomach is right below your diaphragm, all the way up at the bottom of your rib cage. Most people don't think about that, right? How do you know if it's an organ versus a muscle? So those questions are going to tell you that. Which organ? You know, OPQRST, finding out where it hurts. If it radiates, if it's chest pain, same thing. It could be pleural in nature. It can be cardiac. It could be heartburn. It could be all kinds of things. So OPQRST helps you narrow that down. But if it's a broken ankle or something like that, I can look at you and be like, well, I know why you're hurting. You broke your ankle. So if you skip OPQRST for an obvious deformity to an extremity, that's okay. If you skip OPQRST on a cardiac patient or abdominal pain patient, that's a different ball game because that's most of your assessment is trying to figure out what's hurting them. And those questions are going to be where it's at. All right. And then when it comes to ongoing assessment, how often do we reassess our patients?
Critical is 5 to 10 minutes, and stable is 10 to 15 minutes.
I dig that. I was always taught 5 or 15, but yeah, you can go with that. The idea being though is that the more critical the patient, the more often we want to check vitals so that we can catch things that happen before it gets too far, especially when we start dealing with shock. All right, let's take a break. It's been about an hour since we got started. Get back at Eastern time, so 7:12. We'll pick back up at 7:12.
I'm going to shower.
Gonna shower in 10 minutes.
Yep. It's possible. It's
I
quick.
don't know.
I'm
It is
I
absolutely.
can make it
Yeah,
happen.
Get it done,
Scrub
dude.
quick.
It's go.
55 people
As
in
long as the
basic
tones don't
training
drop,
to do it in
I'm good,
5,
dude.
So I got
I'm
it.
on.
I got
I'm on.
faith in you, dude.
Now you did
In the
it.
shower.
Now you did it.
As long as you don't stink later, it's all that matters. All right, 10 minutes, guys. I'll see y'all back at 12 after. What I want to do is I'm going to go over end title, and I'm going to play a video for y'all from YouTube. This is by Jeff Murphy. He's the owner of Master Your Medics, which, by the way, you guys, if you need it or want it, we do have agreements with both Guardian Test Prep and Master Your Medics. So you guys get a discount for them if you want to use them for test prep or tutoring or anything of that sort. But I'm going to share the screen, and we're going to let Jeff teach you about end title.
Pulse oximetry and the end tidal CO2 are always going to be increasingly more important as we develop ourselves and understand the knowledge and the physiology behind them. They're great tools for us to use in order to determine and anticipate different pathologies for these patients that we're going to be dealing with. But in order to really understand how we can use them, we need to understand the physiology behind them, because without that, they're just simply numbers. So let's check it out here, and let's get a deep dive into pulse oximetry and end tidal CO2 and how they can help you as a practitioner. When it comes to pulse oximetry and end tidal CO2, they are often these very basic skills that have a lot of value to us as practitioners in order to determine how our patients are going to fare, how our treatments are doing with these particular patients, because you can trend these vital signs and see how our treatments are doing in order to improve the outcomes of these patients. And so as far as tools go, they're very important for us to use, but we need to make sure we understand the physiology behind them, so that way we're using them properly and making sure that we are using to them the best of their abilities, and not just looking at the numbers, but looking at waveforms and understanding trends of these vital signs as well. So let's get into the physiology of how these guys work. So one of the things that we need to look at first off is what's the difference? Because a lot of the time when we have end tidal CO2, a lot of people like to say that it is all about perfusion. Okay, all about perfusion. But what's interesting about that is end tidal CO2 has a little bit to do with perfusion, but not a whole lot. End tidal CO2 is about determining the ventilatory status of our patient, how well they're ventilating. That's the biggest thing. And we can also start looking into the pH balance and the acid-base balance on our patients as well. And so when it comes to end tidal CO2, that's going to be here, EtCO2, we're going to be looking at more the ventilation status of our patients, which is an important distinction between them, because perfusion is not really what we're looking at here. Perfusion is all about how well blood flow is going, how well we're oxygenating cells. End tidal CO2 is not determining really a whole lot to do with perfusion. There's a couple things you can look at here, but not a lot. So dominantly, or primary reason that we use end tidal CO2 is to look at the ventilation status of our patients. And then we have SpO2. Over here, this is going to start looking at our oxygenation levels, okay? Oxygenation levels at more the peripheral area in order to determine how well our cells are nourished and making sure that they're getting the oxygen they need in order to perform their vital functions. That's essentially what SpO2 is trying to do, is determine that side of things. So really, SpO2 has a better understanding or a better look at perfusion than truly end tidal CO2 can as well. There's so, again, like I said, there's some things we can look at with end tidal CO2 and perfusion, but truly SpO2 is going to see how our end organ or end cell perfusion is really doing and how well oxygen is going to nourish those cells. So that's the biggest difference between the two. So let's look a deep dive on that. So we've talked about how pulse oximeters are able to look at the oxygenation levels of our patients. So it's essentially using an infrared light, and that infrared light is able to shine through our finger or our earlobe, or sometimes it even looks on the temporal side or the forehead side. There's a few different places you can do them, but what it's all looking for is it's shining that infrared light in order to determine how full a red blood cell is. Because red blood cells, they carry heme groups like so, and these heme groups as they fill up with oxygen and offload oxygen, they expand and contract. So for your purposes, when you have oxygen attached to this heme group here, that heme group actually kind of contracts. It holds itself nice and bundled together, and it's essentially saying, hey, I'm full. I no longer need to attract more oxygen. And the less oxygen we have on those heme groups, they actually expand. They reach themselves out, say, hey, I'm available for you. Oxygen, come to me. And so those are the kind of things that we're looking at here when it comes to the red blood cells. So what a pulse oximeter is doing is essentially shining that light through a vessel in order to determine how full those red blood cells collectively are. And so that's essentially what we're looking for in order to do that. Now, keep in mind, there are some things that we need to pay attention to that could skew pulse oximeter results, because they're going to try and come up as this result right here, some sort of percentage to determine how percentage of full our red blood cells are. But there are things that we need to be concerned about, things like nails. Okay, fingernails, if they're gel nails or they have any type of nail paint, nail polish on, or anything like that, can actually skew the infrared light going through in order to determine a true pulse oximeter reading. So those are the things you need to look out for as well. Second thing you need to look out for is hemoglobin saturation of something other than oxygen. So for example, these heme groups, oxygen has a very strong affinity to these heme groups, but something else that has even stronger affinity or attraction to them is carbon monoxide. So in a patient that has carbon monoxide poisoning, that carbon monoxide will actually bind to these heme groups. And so when we shine that infrared light through that blood vessel to look at these red blood cells to see how full they are, they would actually look very, very full. But unfortunately, the infrared light, or the SpO2, can't determine between a full red blood cell of oxygen or a full red blood cell of carbon monoxide. So ultimately, we see a false positive, or often a 99% or 100% saturation in carbon monoxide, because the infrared light is determining those red blood cells are full. It just doesn't know what molecule is actually in there. That's why we get these false negatives or false positives kind of idea. So those are the things you need to look at when it comes to SpO2, but it's really good in order to determine our oxygenation levels for our patients. And so we can use this to determine if we need to intubate, if we need to be aggressive with our airway management, if we need to be aggressive with our ventilation management, how is our perfusion doing? These are the kind of things we can use in order to determine our next steps in order to aggressively treat our patients if this SpO2 is getting worse. So that's the SpO2 and the pulse oximeter, and it's all kind of comes back as this guy right here, this percentage number, and it's all determining how percentage or how full our red blood cells are. And that is essentially it. So this pulse oximeter reading telling us that 91% of our red blood cells are saturated with oxygen. And so that's just telling us and that's the waveform that we can get. And we can start talking about that in a later video, and how you can use the waveform in SpO2 in order to help you determine what you need to do with your patients. So that's what we got here. Now, let's look at the other side of this coin, which is the end-tidal CO2. Now, the end-tidal CO2, again, is looking at ventilation. Okay, it's looking at ventilation, and ventilation is it's a good indicator for certain things that are going on. We can also look at it when it comes to pH imbalances as well, because end-tidal CO2, or particularly CO2, has a direct correlation to our hydrogen concentrations with our free hydrogen concentrations within the blood. So that being said, end-tidal CO2 is great for this. So essentially what it is that we have two different types of CO2. We have PaCO2, okay, and PaCO2 is actually CO2 that's inside the blood itself. Inside the blood. And so when we do an I-stat or pull blood cultures or a complete blood count, we can actually see the blood gases on those, arterial blood gases on those, to determine what our CO2 levels are. So that's essentially what PaCO2 is. End-tidal CO2 is the amount of expired CO2 during a breath of breathing out or exhalation. So when it comes to end tidal CO2, yes, these are typically correlated, the PaCO2 and the end tidal CO2, which is why we use it in order to determine our ventilation status. And the good little rule of thumb is that the more and more these get spread out, okay, between the PaO2 and the end tidal CO2, the more dangerous it becomes. That's more of a critical care thing, but we'll be talking more about end tidal CO2 in later videos. But that being said, that end tidal CO2 is determining how much CO2 is being ventilated out. Now, normal is between 35 and 45 millimeters of mercury. That's normal. And so what we're looking for end tidal CO2 is that if our ventilation status starts to get poor, if it starts to decrease, our patient becomes fatigued, they have some sort of obstructive pathology, something along those lines, what's going to happen is that they can't ventilate out nearly as much CO2, which means that we have an accumulation of CO2 within the blood. Okay, and when we have an accumulation of CO2 in the blood, it correlates to this exhaled concentration, because that exhaled concentration is going to start to go up and up. Because as we get more and more CO2 in the blood, the more and more concentrations in the blood will equate to a higher and higher end tidal CO2, the amount of oxygen that we're being ventilating out. That's how we can determine how poor ventilation is, because the whole point of ventilation here, the exhalation phase, is to get as much CO2 out as we can in order to continue to balance our pH. And so as our ventilations get worse and worse and worse and more ineffective, then our CO2 can't transfer from the blood to the lungs nearly as well, which means that CO2 that's being generated by the cells that's in the blood that's supposed to be transported to the lungs simply can't be ventilated. And so we continue to accumulate our CO2 here, and that correlates to a higher percentage or higher concentration of CO2 being ventilated out, which is ultimately is going to happen here is that we're going to see this end tidal CO2 number continue to go up and up and up as our ventilation status, our inability to ventilate and breathe, gets worse and worse and worse. So very different between SpO2 and end tidal CO2. We're simply looking at two very different sides of the body. One is looking at oxygenation of cells, which is the SpO2, and then we have the end tidal CO2 that's looking at the ventilation status and the direct correlation of CO2 in the blood and the ventilated CO2 as well. So those are the two big things that we have here, and they correlate to simply like this. Okay, and they look like that number there. So again, normal is 35 to 45. So this is a slightly lower than normal range. And then we also have the waveform here, at which we're going to dive deep into the waveform and the number in a later video for you guys as well. So that's a quick introduction of end tidal CO2 and how the difference is between SpO2 and end tidal CO2 and how you can use them together and separately in order to determine how your patients are going to fare long term. So hopefully this is a helpful little article for you, and go ahead and check that out. It's on the EMS Airway article or a page, which is partnered with GEMS as well, talking about pulse oximetry, end tidal CO2, and PaCO2. And that gives you a good article to read and kind of really deep dive into the understandings of both those worlds, just like we've done here in this video. So hopefully you enjoyed that and you're excited for our next ones because they're coming up on Monday. We'll see you then.
All right. So I know some of you all said you couldn't hear it, so I turned the captions on. Hopefully that worked. Any questions on CO2? I know sometimes explaining it one way is a little bit harder to understand than others. For example, he was talking about how it correlates with your PaCO2, which PaCO2 is a little out of range for an advanced EMT because you're getting into lab values that are really given either in the hospital or through critical care, like he was saying, that's even paramedics have to go on to that level of training beyond paramedic school. The way that I explain it is that your cells are going to create CO2 at a set rate, and they don't care about your respirations or anything like that. They're just going to create it. And that's whatever that set rate is could be different for different people. And also depending on what you're doing. For example, if you're running a race, you're going to create more CO2 because more cells are doing their jobs to get you through whatever you're doing. If you're sitting on the couch, you're going to produce less. If you're asleep, you're going to produce even less than that. so on and so on. Tammy, let me move you over to the right room. Give me 1 second. They're doing, I think it was pharmacology tonight. Okay. So anyway, your body's producing X amount of CO2 at a set rate. So determining how much comes out of you, which is what you're looking at when you're doing your end tidal CO2, is based on how fast you're breathing. If you're going to breathe faster or have better respirations, is how Jeff was going over it, each breath is going to produce less CO2 because less, you're getting more carts on the road carrying out that CO2. So every breath is going to bring out a little bit less. If you slow your breathing down, the breaths that you make are going to be blowing out more because that CO2 is building up more between every breath. So the slower you're breathing, the higher the number. The faster you're breathing, the lower the number. And that's going to be a critically important thing to know moving forward, because not only does it tell us a lot about our patients and what to expect from them, but there are also some interventions that we can do, particularly when we're dealing with head injuries and strokes, where we may want to pull their end tidal down one way or the other because it will do certain things to the body. Just some general knowledge there. But I wanted you guys to know what the end tidal was. The only other portion of it that we look at is the waveform. And if I'm teaching it, I'll know to hit it. Otherwise, I'm going to make sure Chris goes over it. When you guys get to respiratory emergencies, I really want y'all to go over waveform. So if he forgets it somehow or whatever, just bring it up, because that's something that you guys can really do a lot with. Same thing with cardiac arrest. Your end tidal and your waveform can go a long way into determining how good the CPR is that's being done on the patient. When the compressions start to get bad, your end tidal will change. We talk about, your patient's breathing, you're going to get 35 to 45. If they're not breathing, you're not going to get that. But compressions still move air because you're also compressing the lungs a little bit. So we expect a little bit of a range, like a low number, but we still expect it from end tidal. And that's a good way to know how your compressions are, if they're deep enough or not. You can tell that by the number. Anyway, any questions on the review of the patient assessment? Because if not, we're going to go through. I'm going to have people run through them. I'll give you some scenarios. But I'm not worried about interventions. I just want to see you guys kind of remind yourselves what it was like to go through the patient assessment when you were in school. Right.
Let's do it.
Let's do it. All right, so I'm going to start at the top. So Brent, do a quick mic check because we're gonna discuss these.
Here.
Awesome. All right, and then Chris Bourgeois, are you good?
Yeah, I'm here.
All right, so we're gonna start with Brent. Chris, you're in the box. You're up next after Brent. Sorry, Brent. Somebody had to be told first without a heads up. All right, let me. Here we go. Okay, so I'm going to give you a scenario. Again, I'm not so concerned about the interventions. I just want you to scene size up, primary. Tell me what you would ask. Tell me what you would get. And that'll be it. So you are responding to a 3-year-old male with trouble breathing.
Okay, BSI scene safe.
Okay, scene is safe. You got your gloves on. You show up and you find a child, as a 3-year-old male, choking with sinuses around the lips. All right, choking on a small toy. So continue your scene size up and just work your way through your assessment.
So we'd start with ABCs.
So before that, remember you've done BSI scene safety.
So we got general impression already. Just gave the general impression. So it's a
Say again?
2-year.
You kind of got muffled. Say all that again.
I said, then we get a general impression, but you pretty much gave that. We got a 2-year-old or 3-year-old patient choking.
Okay. All right.
Unresponsive or responsive?
Say that last part again. You're muffled, man.
Unresponsive or responsive?
Responsive.
They start performing back blows and chest.
Okay.
Uh,
All right. So you've relieved the choking. What's next?
and start getting vitals and
You said you're moving on to vitals.
yeah, monitoring the patient's breathing and starting to check vitals and stuff like that.
Okay. All right. What vitals do you want to get?
Blood pressure, O2 level.
All right. So we got blood pressure, O2. What else do you want?
Skin color to do.
Okay. So blood pressure, O2, skin color, and temp.
Respirations.
Respirations. Anything else?
O2 level.
All right. We already said O2. All right. What else other than vitals? What do you want to do other than that?
Not sure.
Okay. So remember, your secondary. Oh, I'm hearing myself. I'm muting you just for a second. So when you get ready to talk, just unmute. But remember, your secondary assessment is going to be all your vital signs, your history, whatever you deem appropriate. Everybody should get a sample at least, and then you can do a head to toe if you feel like there's some trauma involved. Do your ongoing assessment and then move on. So it's always hard being the one in the hot seat, and it sucks when you're the first one. Kind of what I'm looking at for here, moving forward for tonight. Again, we're not so much getting into the weeds of the interventions. So yeah, like as a choking infant, so you knew you wanted to do the back slaps and everything. That's fine, but I want to make sure that we're all going through all the steps of our assessment. So this is the hard part about this chapter, is that I'm trying to pull you back from the street knowledge and back into the step by step of the checklist. So for example, what I'm looking for is, let's say I'm going to have a patient that's got a stomach ache. What I want to hear from y'all is basically just stepping through your assessment. So BSI, scene safe. Even if I give you the information, just tell me regurgitate that back to me. So if I said you had one patient with a stomach ache, you're like, all right, I got one patient, really don't need any additional resources right now, but I can get a paramedic on standby if you want or whatever. My nature of illness is going to be a stomach ache. I don't see any need for C-spine, so we're covered there. Now I'm going to move into my primary assessment. Patient said they had a stomach ache. I don't see anything else going on, so I have a good general impression. Airway is patent because they're talking to me. Breathing, I'm going to make sure that they're getting adequate breaths, 12 to 20 a minute, or give or take 4. Oxygen if I think they need it. Looking at circulation. At circulation, I'm not so concerned about arterial bleeds or something like that. Circulation, I want you guys to be thinking more along the lines of shock. So when you get to C, you're like, I'm going to check their skin. I don't see any signs of shock. I'm not too concerned about that right now, so I'm not going to deal with it. Going to go ahead and get my patient ready to go to the hospital because everybody's going to go in class. You're not getting any refusals. Now I'm going to move on to my secondary assessment. I can do this in any order. So I'm going to get my vital signs. The vital signs that I want are going to be blood pressure, pulse, respirations, O2 sat, blood glucose if I feel like they're altered, and end-tidal CO2. Just name them off. Even if you decide later on you don't need them in the real world, you may not get all that. That's okay. But just let me know that you know what vitals you're going to get. Then I'm going to do my history. So I'm going to get my sample history. Here's what sample is. Cool. You don't have to ask me the questions. Here's what OPQRST is. You don't have to ask me the question, or actually ask me the question. Just tell me what it is, so I know you know the mnemonic. All right, and then for the head to toe in medical, we really don't have to do it unless we suspect some kind of trauma. Now I'm going to go ahead and be getting to the hospital, and I'm going to do my ongoing every 5 minutes. So I didn't really treat anything, right? I didn't even really ask questions that would differentiate what's going on. We can get into that later on, but I want to make sure that you guys just remember the steps of what you're trying to do. So the checklist that you learned in EMT basic, that's what we're doing right now. I just want to kind of get that flow back into your head, because I know that in the real world, you know it for what it is, which is just a priority scale. But here I want you to kind of get back into that one after the other systematic approach. All right. Chris Bourgeois. Emily, you are next up.
Okay.
After Chris. All right, Chris, you have a patient complaining of chest pain. That's what you're dispatched to.
Okay. Excuse me, BSI scene safe. So I'm approaching a patient. I have one patient holding his chest, complaining of chest pains. Patient responds to me, therefore his airway and breathing is intact. He has good skin color, temperature, circulation is there also. We're going to do a rapid transport decision, make sure ALS is available.
Okay.
At that point, I'll start doing my sample history on him, trying to figure out what's going on and what's causing the problems in my OPQRST.
All right, so tell me what sample is.
Signs and symptoms, his allergies, medication, past pertinent medical history, last oral intake, and events leading up to it.
All right, and then you mentioned OPQRST. What do those stand for? You don't have to ask me the questions. Just tell me what the letters are.
Onset, provoke, quality.
Mm-hmm.
All am I gonna say about OPQ? Radiate, severity, and type. I think it is.
Close. Time.
Time. That's it.
All right.
And I'll start running my baseline vitals, blood pressure, respirations, SpO2. Depending on his sample, if he's diabetic or anything like that, we can do a CBG on him.
Okay.
Then we transport, and while transport, we'll just check interventions and see if he has like nitro or anything like that, depending on his blood pressure.
Okay. Yeah, we start getting the interventions later on.
Correct.
That'll be module 3 when we start talking about interventions, because a lot of them are going to be the same for y'all, but you're also going to have some other stuff like setting an IV, for example, and different meds that you can give through that. Okay. Awesome. How do you feel like you missed anything?
Definitely some stuff out of order, but it was pretty close.
Okay. So remember, the only things you have to get in order are your primary, and you did that. So you got your airway, breathing. You said those were in check, and you listed them in the right order. You said circulation. You missed a couple of things in your size up, which is not a big deal. You missed a couple of vitals, but other than that, you rocked it. So awesome job for being number 2 on the first night. And we're gonna do a lot of this repetitively through the chapters. I'm gonna have Chris doing scenarios with y'all, and then as you start going through your module 3 chapters and getting the interventions, we're gonna start plugging those in. But for tonight, for all of you that are getting ready to do this, what you just heard is pretty much what I'm looking for. Just show me how much of your checklist do you remember. That's all we're covering. All right, Emily, you're up next, and let me pull up the roster. Henry Laurent, you are after Emily Dawson. or Doucet. How do you say your last name, Emily?
Doucet.
Doucet. God, sorry for butchering that.
No, a lot of people around here, it's either Doucet or Doucet, or I mean, technically it is Doucet, but I go with Doucet because it's easier in Central Louisiana.
I get it. My last name is actually Wah, but nobody knows that, so we just go with Roy. All right. So you have a patient that all right. So you're dispatched to a trouble breathing at a volleyball court.
Okay. BSI seen as safe.
Seems safe. You show up to find the patient appearing to have an asthma attack. But again, I'm not worried about interventions. Just go through your assessment.
Okay. Can the patient speak?
Yes.
All right. So his airway is patent because he can speak. How many times a minute is she breathing, or he?
Okay. Are you wanting to get vitals now?
No, I was just going through my ABC. So the airway's patent. The breathing is probably what, labored or so.
Yeah, we'll
Breathing.
say it looks to be in a normal range, slightly elevated.
All right. And the skin color is good.
Pale.
Pale. All right. So I have a patient currently having an asthma attack, talking to me, breathing kind of wheezing, pale colored, blood pressure. I'm gonna get blood pressure, SpO2, SpO2, blood pressure, heart rate,
All right. Blood pressure, heart rate,
CBG,
SpO2, CBG.
end-tidal,
Okay. That's a good one.
and then go into like my sample and my QRS. Sorry guys, it's been a very long day. I had a crazy patient.
All right. All right. So for you, I want you to give me a question about quality.
About
What would you ask about quality? You mentioned OPQRSC. Chris already said what the letters were for, so I want you to give me a question that would ask what the quality is. The Q
like
in the
what like how are they feeling when they breathe? Does it hurt? Does
Okay.
it is it pain to it?
Okay. Awesome. Yeah. So just basically describe the discomfort, right?
Yeah.
All right. So you've got your vitals, you've got your history.
Okay, and then I'm gonna load up, go to the hospital, and check vitals and any interventions on the way about every 5 to 10 minutes.
Okay. Do you feel like you missed anything? How do you think you did?
I think so. Probably missed something somewhere in there, but I think I've got the basics.
You hit the high points. That's for real sure. You did great there. Y'all don't forget the other steps of your size up. So BSI scene safe, everybody is knowing to say that. That's great. The way that your scenarios will work, if you do a psychomotor, and they're supposed to be making the new registry test have all this in there. So once you say BSI scene safety, that tells me that you're on the scene. So I'll give you some more information. However, I still want you to do your size up. So give me the number of patients, need for additional resources, MOI, NOI. Even if I gave it to you, just kind of regurgitate back that you're acknowledging that's a step in your checklist. Because again, that's all we're going over tonight is just trying to get that checklist discipline back. I know that some of you have been in the field as basics for a long time, and this has all become second nature, and it runs through the way it should, which is quick, fast, almost instant, but we got to get back into that school mindset. But other than that, I think most of what you missed, Emily, was just in the size up, so no big deal. Yeah, I thought you were about to jump out of your primary before you finished it, but you corrected me and said that you were just trying to get an idea of the adequacy. So good job.
Yeah, just.
All right.
Oh, you're good. Thank you.
Yep. All right, Henry, you're up, and Jared Charpentier. Tell me if I got that right.
Stand by. Stand by.
Okay.
I want to hear about
Oh, y'all.
had it like injury number. Discussion. And Otterwell Drive and Macquarie Street, Otterwell Drive.
Saved by the bell.
Y'all gotta go.
Go 20. I'll be back.
All right. Lucky. All right, I'm gonna reset the mutes. All right, well, if he's gone, Jared, are you on the same? Are you going with him?
Negative. I'm off.
All right, so you're up. Jeremy Sitter, you're gonna be after Jared. All right, sir. Jared, I'm gonna give you a patient that's got a stomach ache.
Oh boy.
All right, so same thing, no interventions, but we're gonna play around a little bit with the questions. So
Okay.
let's go ahead and start with the top.
All right. I'm gonna consider BSI as my scene safe.
BSI is good, scene is safe. You show up and you find a patient that's doubled over in pain, 24-year-old female.
Okay, I have one patient, 24-year-old female, doubled over in pain, complaining of stomach pain. So I've determined my nature of illness. She's complaining of stomach pain. I'm going to consider if I need any other assistance. One patient. I'm going to consider a ALS intercept on this because it's an unknown illness at this point.
Okay.
Do I have any concerns for spinal immobilization?
None that you can see.
Okay. Let's see. General impression of this patient right now is poor. Patient is responsive whenever I approach.
Yes.
It's a question.
Yes.
Okay. Let's see. I'm going to try to assess the area where she's having pain. See if I can palpate the abdomen. See if maybe remove clothing. See if any obvious injuries externally that I can see.
So she is doubled over and holding her right lower quadrant.
Okay. Doubled
So
over,
she's
holding right lower.
guarding that area. Yep.
Repeat yourself. I'm sorry.
She's guarding that area, the right lower quadrant.
Okay. All right. How's her breathing?
Labored, well, not labored really, but fast. She's tachypnic.
Okay. All right. I guess at this point I will assess vital signs. I'm going to ask
Okay.
for, let's see, I'm going to assess blood pressure, pulse, respirations, you say, in a shallow and rapid.
Mhm.
Let's see. Mhm.
Blood pressure, pulse, and respirations is what you've got so far.
Okay.
You
All right.
wanna-
All those. What are those vitals? What did I get?
Well, just tell me which other vitals you want. Name off all the vitals you want.
Okay. Blood pressure, pulse rate, respirations. Probably check blood sugar.
Okay.
O2 sat.
There you go.
End tidal, CO2. Maybe skin temperature, color.
Yeah, you can get off in the weeds with some vitals.
Yeah, I'm just trying to cover the bases here. I mean, like you said, if I walk up and she's a weird color, it's going to be apparent to me, so I'm not going to have to think about it. It's going to jump at me.
Right.
Things like that.
Pause. Sydney Clark, I'm going to go ahead and move you to the basic room. Is that why your hand's raised?
Yes, thank you.
No problem. All right, Sarah, continue. I'm sorry.
Okay, so again, I'm going to try to get her to allow me to assess that area, remove clothing as necessary, see if there's obvious deformities or any injuries visible externally. Try to palpate, and like you said, we've isolated. She's guarding the lower right quadrant. Let's see. Try to get a sample history from either the patient or somebody with her. Can she respond to my questions?
She can. And so let's do that. Let's go through the questions.
Okay.
So what do you want to know?
I want to know signs and symptoms. She's, complaining of stomach pains. Um, let's see. Ask her of any allergies. Has she had any? Does she have any allergies that would pertain to the complaint that she's having?
No allergies.
Okay. Is she taking any medications?
She takes Tums for heartburn.
Okay. And her past medical history. So obviously she suffers from heartburn. Does she have any other pertinent medical history?
No.
No, just a random stomach pain to the right lower quadrant.
Yep.
Okay. What was her last oral intake?
She had lunch at like 11:30, so 6 hours ago, something like that.
Okay, lunch 6 hours ago. Were there any events that led to this illness?
Nope, she had just gotten home from the gym.
Just got home from the gym. Okay.
Yeah, but she wasn't hurting at the gym. It didn't start there.
All right. What else? What else? So again, my impression of the patient is poor. We need to consider transport, rapid transport, and continue to assess the patient. Make sure and that she maintains a good airway and the vitals remain stable.
Okay, awesome. All right, give me 1 second while I get Miss Mertz back into the right room. I'm working on it. I know. I got to figure out how to let it to where y'all can do this on your own. Let me see. Yeah. What you need? You can unmute if you got to tell me something. Nothing? Okay. All right, give me a second. There we go. All right. All right, sir. So good job on the questions that you remember to ask. You asked me the sample questions. You asked me OPQRST. Did you, first of all, and the assessment as a whole, did you realize at any point that you might have forgotten some things?
Well, I'm sure there's a couple that I forgot. I was trying to center my assessment around stomach pain.
Okay.
Try to remember things specific to that.
All right. So the big thing was make sure that you verbalize everything in your primary before you move on to your secondary. That's if you
Okay.
think back to EMT, that's a critical fail. So you want to make sure, even though you did say, my patient's talking to me, right? So that serves two purposes. One, it tells you that I'm conscious. Two, it verifies you've got an airway, because if they couldn't breathe or have an airway, they wouldn't be talking to you. But I need you to verbalize that. Say, all right, not just are they talking to me, but why is that important? So I know they're conscious and I know that I have an airway. You did pick back up with breathing, and you kind of got circulation, because I think you asked me about the skin tone. So good there. You got your vitals. You asked me your sample and your OPQRST, which is great. Now, what kind of patient did I give you? Tell me the demographics of the patient you had. Do y'all remember?
Appendix.
Could be, right? How do we know?
Hey Rob, can you hear me?
I can hear you now.
Yeah, I got muted there. I was talking and talking, and I couldn't. You weren't responding to me. I figured out I was muted. I'm sorry.
That's all right. All right. So anyway, what kind of patient?
I was thinking age of pregnancy. Suspect a possible pregnancy.
Absolutely. How would you know? What are some questions because those questions don't fit in the OPQRST and sample. So some, strokes, you're going to have extra questions, possible pregnancy, and abdominal pain, especially just in general. There's
That's
always
the first thing I thought. Yeah.
So what are
So,
some other
well,
questions that you
well,
could have asked?
when was your last menstrual cycle?
Yep. Okay. Yeah, because if it's been more than a month, she's late, right?
Mm-hmm.
Even if she, all right, now here that I get me on another soapbox. I'm of the mindset that every woman of childbearing age is pregnant until proven otherwise.
Yeah.
So I'm gonna ask because I'm supposed to, but I'm gonna take that answer with a grain of salt. Not that I think the patient may be lying to me, unless she's like 16, 17 years old, then they may be.
She may
But
not
a
even
lot of
know.
times she may not know, right? Because there's a lot of women that don't know or they don't consciously think about it when they're doing it. Antibiotics will neutralize birth control. So if she's on antibiotics or something and she's like, no, I can't be pregnant because I take the pill or whatever, antibiotics neutralizes that while you're on it. So
When I asked about medication, she told me that she's only taking Tums for heartburn.
right. So, but keep that in mind. If you get a patient that says they're on antibiotics because they got an infection from a rusty nail or something like that, or they got cut and they're on antibiotics, that will render birth control useless for the duration. It'll be fine after they're off of it, but the body can't really handle both. It doesn't work right. So, um, a lot of people think they put a lot of faith in their birth control, but there are things that can mess it up, even just temporarily. All right, so she could have been pregnant. That's something to be concerned about. But being that it's the right lower quadrant, we're also possibly concerned about appendicitis. What's something that you guys can remember from either your street experience or EMT basic if they taught it to you? How can you tell the difference between appendicitis or something else?
Rebound pain.
Right? Describe that to me.
When you push on it, it doesn't hurt, but it hurts whenever you release.
Okay. Absolutely. So one of the issues that we run into a lot of times is that if a patient's really having appendicitis, they're not going to want to move their hand for you to press on it. So can anybody think of an alternate idea? Now, you're absolutely right, but there's another way of going about it. Michael, you may have something?
A fever?
Could be. Yeah, if you're getting temps in the field, you could find that something like that may cause a fever because the body thinks that it's an infection. All right. As far as testing pain though, anybody learned about the foot? If you think that your patient may have appendicitis, instead of pressing where their hand is and causing excruciating pain, um, you can take your hand and tap them on the bottom of their right foot on the right heel. If they feel that, it may not necessarily pain, but if they feel that up in the right lower quadrant, it's a percussive thing, and I forget there's a term for it. I'd have to Google it, but that's just as good as the rebound rule. So if you don't want to make your patient scream in agony, you can just tap her on the foot and ask her if she feels it up there where the pain's at. And if she does, it's probably appendicitis. Of course, it's going to take a CT or a ultrasound to figure that out for sure, but that's why they need to go to the hospital. Okay, Josh, that's fine. So we're actually gonna call it a night here because I know it's 8 o'clock and really we're just doing assessments anyway. There's nothing new to go over. You guys did great. Again, I'm gonna get with Chris. We're gonna try to do this every night just to get it back to where it's second nature to you to do it the school way. That way you're prepped when you go to take the registry. We kind of that's the hardest part about advanced EMT really is just kind of breaking that street habit and getting you back into school mode. So I appreciate that. I'm glad y'all liked it. So before we call it a night, do y'all have anything for me? Anything we need to go over? Any questions? You guys kind of have it a little bit harder with the skills than the basic students do.
The test is due in 72 hours?
Tonight, yes. I will get with Chris, and the only reason he wasn't teaching tonight is because he had to travel. But we'll make sure that the test don't close early. I think that we're at the end of module 2, or we're nearing it. So I got to make sure that the dates are right. But yeah, 72 hours from today, you can take this test. And then be good. NREMT still using skill sheets at the moment. Yes, and the skill sheets are pretty much the exact same because your assessments don't change, only the interventions that you are allowed to do. So even if you're still running around with basic skill sheets, they will work. It is all the same information. Yeah, Jeff, I tell you what, man, Jeff is amazing. I'm not just, tooting his horn, but I'm a fan. Even for my own continuing education, I use a lot of Master Your Medics videos, advanced skills, IVs, and stuff. So you should get the skill training at your first skill day. Hopefully, Lindsay, because you were at Biloxi. Yeah, in fact, I know y'all did it because Rob was talking about the fact that we only had 14 gauge needles and y'all were obliterating the IV arm. Not through any fault of your own, but I mean, you could see through a 14 gauge. As long as you did that at the first skill day, then you're good to go for your clinicals. That's why we have to have you do that first. Didn't get any skill sheet. Oh, I see what you're saying. That's all right. I need to get more IV arms anyway. So the advanced EMT and the paramedic, if you just Google AEMT skill sheets, NREMT, it'll lead you right to it. It's kind of hard to navigate there on the NREMT, but they're all there. That way you can see the steps. All right. Well, if y'all are good, go ahead and stop the recording.